ओम अज्ञानतिमिरान्धस्य ज्ञानाञ्जनशलाकयाः चक्षुरुन्मीलितं येन तस्मै श्री गुरुवे नमः. A very good afternoon to all the participants who have joined us for the session today. Myself, Dr. Pooja, second year KCPG scholar, Department of PG Studies in Kayachikitsa, TGAMC Ballari. Taranath Government Ayurvedic Medical College and Hospitals welcomes you all to the Dr. M. Eshwar Reddy Memorial Kayachikitsa Webinar Series 2021 on the topic Rajyakshma in the memory of late Dr.G.Shrinivasa Acharya ji. We Taranath Government Ayurvedic Medical College and Hospital are blessed with Swargya Pandit Sir Taranath's name. On the occasion of World Tuberculosis Week, we Department of PG Studies in Kayachikitsa decided to conduct a webinar series. So here is our fourth session and today's guest speaker, Dr. K. Nagaraj Sir ji. It's my privilege to welcome you, sir.
Thank you.
Sir have completed his MBBS and PG in VIMS Ballari. Sir have worked in PHC in Andhra Pradesh. Sir have worked as a district family planning officer. Sir had worked from 1987 Feb to May 2000 in Department of Radiology, hired as a HOD of Radiology. Sir has presented 12 papers in both the national and the international conferences. Sir presently working as a consultant radiologist TGAMC Ballari. Now I request our beloved Dr. Pushpalata ma'am, Assistant Professor, Department of PG Studies in Kayachikitsa, to welcome sir. Thank you.
Very good afternoon to all. First of all, I welcome Dr. Nagaraj sir, retired HOD, Department of Radiology, VIMS Ballari. On behalf of Principal HOD, PG Studies Department of Kayachikitsa, I welcome you, sir. Sir, it's our fortune to have a webinar online with you regarding the subject Radiological Changes in Pulmonary Tuberculosis on the special occasion of World Tuberculosis Day. Once again, I welcome you, sir. For today's postprandial session, our students are eagerly waiting to listen to your session. Sir, please carry on the session. And next, I would also like to thanks to our beloved principal madam, who is always backbone and inspirative, motivative to our departmental academic-oriented activities. And also, I thanks to my beloved and respected teacher, Professor, Head of the Department of Dravyaguna, Dr. Rajshekar Ganigar sir, who is always supportive and initiator to perform this type of events. Thank you, sir. And I also thanks to our beloved and respected Head of the Department, Dr. Madhav Dikavi sir, PG Studies, Kayachikitsa, who is always dynamic and enthusiastic in organizing this type of beautiful events, which are very useful to our PG students and all other participants. Thank you, sir. And I also thanks to my beloved colleagues, Dr. Farida madam, Dr. Lalita madam, and all my PG scholars and all participants. Thank you one and all. Sir, once again I welcome you, sir.
Thank you.
To this postprandial session.
Thank you very much. Yes. You can widen this screen.
This PPT screen. It will be widened for everyone. Okay. So use it.
Yeah. Good evening to all of you. My sincere pranams to Dr. Eshwar Reddy, who is my very close friend of mine and also very good associate of me. and we are from neighbor village. And also my sincere pranams to Dr. Srinivasa Acharya, and also my sincere foot-touching pranams to Pandit Taranath and also Dhanvantari God for having given health to all through the Almighty's work. Now the topic assigned to me for today's discussion and the webinar is radiological changes in pulmonary tuberculosis. Now, before going to the real story of tuberculosis, let us have a few glance about the history of tuberculosis. Historically known by a variety of names, including consumption, wasting disease, white plague, TB was a death sentence for many people. Next, please. Next. Yes. Until mid-1800s, many believed TB was hereditary. 1865, Jean Antonia Villemin proved TB was a contagious. 1882 is a very big milestone where Dr. Koch discovered Mycobacterium tuberculosis, the bacterium that causes tuberculosis, which appears in microscopy as a cigar bundle appearance. Before many patients were sent to sanatoriums. Patients followed a regime of bed rest, open air, and sunshine. TB patients who could not afford the sanatorium often died at home only. Next slide. Yes. Global burden of tuberculosis. In 2016, 10.4 million new TB cases have come. 1.8 million died from the disease. 0.4 million HIV plus positive patients, and 4,80,000 people developed MDR and TB, and 1,73,000 deaths from the tuberculosis. 60% of the new TB cases, India, Indonesia, China, Nigeria, Pakistan, and South Africa is contributing 60% to the world statistics. Epidemiological factors, source of infection, human source, sputum positive cases, bovine source, infected milk, communicability, persons is infecting as long as they remain untreated. Effective treatment reduces infectivity within 48 hours. Now, era of conventional chemotherapy is Dr. P.V. Benjamin, father of anti-TB movement in India. Now, this is a line diagram, how exactly tuberculosis causes and transmission of tuberculosis and progression of latent infection. Next slide, please. Typical radiological patterns may be considered under the following groups. Typical radiological patterns of pulmonary TB, post-primary TB or reactivation TB, patterns encountered in both primary and post-primary TB, and complications and sequelae of the TB. Now, the whole tuberculosis is divided into primary tuberculosis, next is secondary tuberculosis. Primary tuberculosis means infecting a virgin soil is called as a primary tuberculosis. The most common abnormality in children is lymph node enlargement, which is seen in 90 to 95% of cases. This is called as lymphadenitis, lymphangitis, or in parenchymal lesion, this is called as Gons foci. This is more common in children. Next, the most common abnormality, the 10-year-old child with the tuberculosis shows widening of the right paratracheal strip. Now, this is the radiological finding with a congestion of the right lower jaw. Next slide, please. Yes, CECT where shows tuberculous nodes that show central areas of low attenuation suggestive of caseous necrosis and peripheral rim enhancement. So this is a place where CT scanning is going to give a wonderful information about the lymph nodes, where we have seen in the chest radiograph only widening of the tracheal strip, but whereas in the CT you are going to see hypodense areas everywhere with central necrosis and rim enhancement is seen, and this is the typical picture of the caseous necrosis and peripheral rim enhancement or the shows tuberculous nodes are confirmed with this. Next slide, please. Now, again here, one more case with superior mediastinal widening, where there is a widening of the mediastinum is seen, but we are not aware whether it is what is the cause for it. Then immediately CT scan is taken, and we confirmed it is a tubercular lymph nodes by seeing the physical appearance. Later on, other investigations have been taken to confirm the tuberculosis. Next slide, please. Now, Gaunt's focus, as I have told you earlier, Gaunt's focus may be visualized on the chest radiograph as an airspace opacities. Airspace opacities, lymph nodes, and also you are going to see the lymph nodes, and here also one node is there, and here parenchymal lesion is there. So these things contribute for the Gaunt's focus may be visualized on the chest radiograph as an airspace opacification. Next slide, please. Yes, Gaunt's lesion focus. Small 10 yellow subpleural granuloma in the mid-lung field on the right side. And over time, the granulomatous decrease in size and can clarify, leaving a focal calcified spot on a chest radiograph that suggests remote granulomatous disease. Then you have to go for further lesion. This is a pathological specimen of the lung tissue. Next slide, please. Now, Gaunt's complex. What is this Gaunt's complex? Now, typical of primary tuberculosis in a child. Parenchymal involvement is more in adults, but lymph node enlargement is more common in children. And one thing is very clear, this Gaunt's complex in children is not a contagious, except pulmonary tuberculosis with the involvement of the parenchyma is highly infective from one person to another person. Otherwise, other lymph node enlargement tuberculosis is not going to have a person to person. It is going to transmit. Next slide, please. Now, Ranke complex, the combination of calcified lesions of the lung and lymph node is referred to as a Ranke complex. Here, calcified lymph node is there. Here also calcified lymph node is there, and the combination of calcification lesions of the lung and lymph node is referred to as small calcifications are here, and here also you are seeing subtle calcifications. Here also lymph node. This is Ranke complex. Yes, airspace consolidation is usually unilateral, is evident radiographically in approximately 70% of children with primary PT. Many of the children with this Gaunt's foci will go in for consolidation with a airspace lesion, which is a consolidation, which is a common factor in the children with the primary tuberculosis. Next slide, please. Now, obtained a level of right middle lobar bronchus, where you are going to see there is consolidation is there, narrowing of the bronchus is seen, and because of the pressure effect of these lymph nodes, and also lung parenchymal lesion is seen. Next slide, please. Now, the tuberculosis, especially in lung, will affect almost all parts of the lung field, which generally we will see. One is lung parenchyma in the form of pulmonary tuberculosis, pleural in the form of pleural effusion, pericardium, pericarditis, tubercular pericarditis, and also rib tuberculosis, spine tuberculosis, lymph node tuberculosis, medial end of the clavicle, tubercular medial end of the clavicle, and also shoulder joint, which is also tuberculosis can be affected. This is called as dry tuberculosis. So pleural effusion is usually unilateral, and due to subpleural infection, pleural effusion are more common in adults with primary tuberculosis, 40%. This is the previous slide, please. Previous slide. Yes. No, previous slide. Yes, this is the pleural effusion, where it is concave towards medial side and merged in the lateral aspect. Next slide, please. Now, atelectasis. Atelectasis is also called as collapse of the lung field. Now, here shows a right upper lobe airspace opacity adjacent to the trachea. In addition, there is a elevation of the minor fissure is there, suggestive of the collapse. In consolidation, elevation of the fissure will not be there. In case of collapse consolidation, elevation of the fissure will be there. And also sometimes dome of the diaphragm is also elevated. But here it is only the fissure which has been elevated. Airspace, this one is there. So consolidation with atelectasis, that is the volume loss, that is collapse of the lung is seen. Right, next slide please. Post-primary tuberculosis, focal or patchy heterogeneous calcium consolidation involving the apico-posterior segment of the upper lobes and the superior segments of the lower lobes are the typical post-primary tuberculosis. Where in post-primary tuberculosis, after the tuberculosis primary lesion, patient will go for severe pulmonary lesion, both on the upper zones. Non-homogeneous opacification is seen, and patient must be again re-examined for the sputum for A and B. This is a active tuberculosis. Now, the same film taken in the posterior aspect, and they say why it is only confined to the posterior segment of the apical region. Probably devoid of lymph nodes, and also air perfusion is very less. That's why the apex is more affected than the other zones. Yes, post-primary tuberculosis, reactivation tuberculosis is also called predilection for upper lobes, lack of lymphadenopathy, and propensity for cavitation. Post-primary tuberculosis, distinguishing feature in the case of tubercular lesions. Next slide, please. Yes, the predilection of, for the upper lobe is thought to be due to decreased lymph flow in the upper regions of the lung, as alternative explanation is the presence of higher oxygen tension in that region. Next slide, please. Yes, cavitation. So, in tuberculosis, non-homogeneous opacification, cavitation, destruction, collapse consolidation, and also hydropneumothorax, and also pneumothorax, and pyothorax, and also you are going to get a pleural effusion of all the types you are going to get in the tuberculosis. One amongst it is cavitation. X-ray showing cavitation, consolidation in right upper lung zone, and multiple ill-defined nodules in both the lung fields is the typical picture of a tuberculosis. Immediately he has to be subjected for the treatment, where the clinicians are the best people to decide what type of treatment to be given. This cavity is highly infective. With or without cavity with bilateral involvement of the lung fields is highly infective to the others. Next slide, please. Now, this is the CT film where you can see a cavitation with a surrounding involvement of the interstitial lung tissue, where it is going to cavitation, and 3 in bud sign is indicative of an active disease process and usually heals as a linear or fibrotic lesions. So this is a very, very, very typical of the cavitated tuberculosis, which is this is a 3-bud appearance, and which is a typical sign where you are going to get a good information in CT scanning when compared with the chest radiography. Next slide, please. Now here, another thing is miliary tuberculosis. So miliary means whole lung fields are having miliary mottling appearance. Miliary mottling means small dot-like appearance all over the lung field. Miliary tuberculosis refers to widespread dissemination of the TB by hematogenous spread, seen more frequently in reactivation TB seen in patients with location. So this is the miliary tuberculosis, which is very, 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 very common in the to widespread dissemination of the TB by hematogenous spread. The treatment again left to the discretion power of the clinicians. Next slide, please. Now, this is a characterized radiographic and high resolution CT finding consists of innumerable 1 to 3 mm diameter nodules randomly distributed throughout the lung field. This is the miliary pattern, and treatment is very wonderful. I think, if I am correct, they are going to start antibiotics, anti-tuberculosis, and other things they may start. I don't know. They are the best people to decide it. Next step, please. Now here, chest radiograph shows innumerable millet-sized nodular opacification and ground glass opacification in both lung fields, again suggestive of miliary tuberculosis. I forgot to tell you the other organ which is left in the chest. In female, the breast tuberculosis is also recorded in the literature. So breast can also be affected with the tuberculosis. Next slide, please. Now, tuberculoma. Tuberculoma is nothing but a solid lesion in the lung field. Where you will get homogeneous, rounded, well-defined, benign lesion. Many times we will neglect, we will think in terms of so many things. But in India, first you have to rule out tubercular lesion, then you can go ahead for further. Well, how to do further is CT scanning, and also further blood investigation and other investigations to be done. So, sequelae of healed primary TB, but may be seen 3 to 6% of cases of post-primary tuberculosis as the main or only abnormality in tuberculosis, that is the tuberculoma. Next slide, please. Now here, the solitary tuberculoma in a 59-year-old man with post-primary tuberculosis, computed tomography scan shows a well-defined round 1.5 mm diameter nodule with dense opacification, dense calcification in the superior segment of the right lower lobe. This is the superior segment of the right lower lobe, very clearly seen when compared with radiography. So this is also one say that it is a healed tuberculosis. Next slide, please. Yes, healed TB. Now, once the patient is completing the treatment, then he will get the chest findings as healed PT. Normally, multiple calcified opacifications we have to see. But in my experience, as it dates back to 1972 and 73, when I was going to TB sanatorium, the tuberculosis treatment is streptomycin, INH, and PAS they were giving, and a wonderful bilateral calcified opacifications were seen. But now calcified nodules are very less, which is now second line of treatment and latest line of treatment. I don't know what is the reason. Calcified nodule consistent with a calcified granuloma. In addition, there is a bilateral apical pleural thickening is seen. Now bilateral apical pleural thickening is seen, not well appreciated, but anyhow, here there is some amount of thickening is there, which is a clear-cut picture that patient has a tuberculosis. Next slide, please. Now this is the now here we are having a wonderful picture where there is a trachea deviated towards the right side, and also multiple fibrous bands are seen, cavitation is seen, and also pleural effusion is seen. And these are all the sequelae of the post-tubercular lesions where there is a collapse and fibrosis. In collapse, trachea is simply pulled towards same side. But in case of fibrosis, trachea is shrunken and also deviated towards the same side with cavitation. This fibrosis is the post-tubercular sequelae, and pleural effusion is also there. These people will land up into the hospital with hemoptysis continuously. Next slide, please. Complications and sequelae. Next slide, please. Yes. Aspergilloma, which aspergilloma is nothing but a fungal etiology of the lung field, highly dreadful condition of the lung where patient survival is very remote. Once the tuberculosis cavity can be colonized by Aspergillus species and present as aspergilloma. Aspergilloma, which is a very alarming that patient to be attended on top priority. Next slide, please. Now, spherical nodule or a more spherical biconcentric shaped area of decreased opacity of this one adjacent to the cavity wall. So, this is the cavity wall, and you are going to see the aspergilloma. Next slide, please. So, this is the, now we can appreciate what is the best thing that you are going to get by CT? You are going to see the air, and you are going to see the opacification here, and clear-cut picture of the aspergilloma we are going to see in the left upper zone. Next slide, please. Bronchiectasis. Bronchiectasis is in 30 to 60% of patients with active post-primary tuberculosis, and in 71 to 86% of patients with inactive disease at high resolution CT. Bronchiectasis may be tubercular, may be non-tubercular. Next slide, please. Here, CT scanning HRCT shows, high resolution computerized tomography shows traction bronchiectasis in the right upper lobe. These are all bronchiectasis changes. Here, tubular, saccular, cystic appearance is there, and this is a cystic appearance of the tuberculosis where all of the lung field is flooded with the bronchiectatic changes. Next slide, please. Here, tuberculous empyema, another dreadful complication where there will be this case demonstrates a left pleural effusion, left with air fluid levels consistent with a hydropneumothorax caused by bronchoclural fistula. Diagnosis of hydropneumothorax is based on the presence of pleural effusion accompanied by an air fluid level within the pleural space. So here there is a emphysema is there. There is a tuberculous emphysema is there, small cavity is there, pleural effusion is there, air and fluid levels are seen. There is a fistulous tract which has been very badly neglected tuberculosis with opposite lung emphysematous changes. So this patient has gone for pleuro. This case demonstrates a left pleural effusion by bronchopleural effusion. So between the bronchus and the pleura, the fistulous tract will happen, and then patient will have a very horrible day and night because of the breath. Next slide, please. Now here, bronchopleural fistula, very well demonstrated here. Here there is a one guide is inserted, and empyema may also communicate with the bronchial tree by bronchopleural fistula and can show an air fluid levels. So air fluid levels here, bronchopleural fistula with air fluid levels, that is the empyema. Even empyema is also having a contact with the bronchus. Next slide, please. Vascular complications. Now, bronchial arteries may be enlarged in bronchiectasis associated with the tuberculosis. Now here, Resmacin aneurysm. Resmacin aneurysm is a pseudo-aneurysm that results from weakening of the pulmonary artery wall by adjacent cavitator of the tuberculosis. Adjacent cavitator of the tuberculosis is going to cause weakening of the aneurysm, or the pseudo-aneurysm that results from weakened aneurysm is a pseudo-aneurysm that results from weakening of the pulmonary artery, where pulmonary artery is having aneurysm, is only pseudo-aneurysm, which will disappear after the pressure effects will go. Next slide, please. CCT obtained shows cavitation, consolidation, air crescent sign in left upper lobe, left upper lobe, air crescent sign is there, cavitation is there, consolidation is there, and the upper lobe in the CCT where active tuberculosis is there. Next slide, please. Pneumothorax. Now, pneumothorax is one of the complications in case of tuberculosis, where pneumothorax occurs in approximately 5% of patients with post-primary TB, usually in severe cavitatory diseases, where it will have this pneumothorax, and then it is going to cause a lot of discomfort to the patient with a linear atelectasis and minimal pleural effusion on the right side. Again, pleural empyema, bacilli can enter the pleural space from juxtapleural caseating granuloma or via hematogenous dissemination, and going to cause pleural empyema. Empyema is nothing but collection of pus, infected material. Next slide, please. Now, tracheobronchial stenosis, because of the cavitation and also lymph node, there will be narrowing of the tracheobronchial stenosis will be there in case of tuberculosis. Next step, please. Bronchogenic carcinoma. Now, tuberculosis may predispose to the development of bronchogenic carcinoma by local mechanism, scar cancer. Carcinoma may lead to a reactive of the TB, both by eroding into an encapsulated focus and by affecting the patient's immunity also. So, very dreadful condition. Do not neglect about the tuberculosis. Next slide, please. This is the CT scan where you are going to have a tubercular healed lesion. Surrounding that, there will be SY lesion, space occupying lesion. Probably it may go for malignancy. Next slide, please. Bronchioliths, small areas of involvement of the bronchioliths is seen. This is also one of the complications of the post-tuberculosis lesion. Next slide, please. And pericarditis. Now, here you are seeing widening of the cardia and also flask-shaped cardia, bilateral pleural effusion, basal involvement of the patchy pneumonitis, and also this is tuberculous pericarditis, reported to complicate 1% of cases of TB, is commonly caused by extranodal extension of tuberculosis adenitis into the pericardium. Right. Next slide, please. So this is the CT scan where it is giving a clear-cut picture of the cardia. Next slide, please. Tuberculosis and HIV. As the CD4 lymphocyte count declines, the radiographic findings look more like those seen in primary disease. The radiographic capacities may be in the lower lung zones and multilobar in nature. Lymphadenopathy is the more common in case of tuberculosis with HIV. Now, here is a collapse consolidation is there, opacification is there. Again, you have to rule out the tuberculosis here. Next is the spontaneous pneumothorax in 47-year-old man with extensive pulmonary tuberculosis. High resolution scan shows extensive areas of consolidation, cavities in both upper lobes, and pneumothorax is seen here. So, consolidation, cavitation, pneumothorax, suddenly spontaneous pneumothorax can occur in some patients also. Next slide, please. Again here, bronchoclural fistulas, which has been demonstrated with a air and fluid level and also cavitation and also opacification in the upper jaw and also non-homogeneous opacity in mid-jaw. Again, it is a tubercular complication. Requires immediate intervention to put the ICDT. Next slide, please. India is responsible 1/3 of the global cases of tuberculosis. 1.8 million new cases of tuberculosis are reported every year. So, 95% mycobacterium tuberculosis, 5% atypical mycobacterium tuberculosis. Next slide, please. Lymph node enlargement, as I have shown earlier, pulmonary TB, mediastinal and hilar lymph node enlargements are seen. Next slide, please. And gangliopulmonary TB, where specific to primary TB, mediastinal and hilar adenopathies, and less conspicuous parenchymal abnormalities, and preferential occurrence in children. It has been distinguished as childhood tuberculosis. Next slide, please. Yes, extensive. Now we studied extensively about the pulmonary tuberculosis, but we must also be aware that extrapulmonary tuberculosis can also occur. One is this body of the vertebra tuberculosis, where it has been collapsed, where you are going to central tuberculosis and peripheral tuberculosis. This may be secondary to that of the primary focus. Next slide, please. Now here, tuberculosis of the brain, where meningitis you are going to develop, and also obstructive hydrocephalus, which is very, very common in children, and also adults it's very rare, probably they might have developed immunity and taking the treatment. And this is the obstructive hydrocephalus there, where dilated ventricles are seen. Next slide, please. Again here, solid caseating granuloma. Here there is a granuloma is there. So this granuloma is one which is of tubercular etiology and going to cause a tubercular foci in the brain, and patient will have epilepsy. And later on, if investigated detail, then you will get the focus and treat the patient accordingly. Next slide, please. Now, this is the tuberculosis of the urinary tract, where you are going to get stumping, distracting, and this one infected calyces, and also shortening of the calyces, and also dilated, obstructed ureter, and also you are going to get a thimble bladder, and straight ureters are seen. How to diagnose this renal tuberculosis vein? Send urine for culture and also for tuberculosis AFB, then you are going to get the report. Next slide, please. Complication of pulmonary tuberculosis, as I told you, hemoptysis, pleurisy, pleural effusion, empyema, pneumothorax, aspergilloma, and endobronchitis and bronchiectasis, and laryngitis, and cor pulmonale, and CA bronchus, and enteritis, and miliary tuberculosis, and HIV-related opportunistic infections are very common. Now, the home taking message is any lesion in India in upper zone must be ruled out for the tuberculosis. And any patient with loss of weight, loss of appetite, and also low-graded fever, not responding to any antibiotics, and treat in terms of go investigate for the tuberculosis. Next is, once it is investigated, most of the time we ask for the sputum for AFB on the same day, but it is not so, because you give the cup to the house, 24 hours sputum to be collected and brought it for the AFB, because the 24-hour sputum will come nearer to the bronchus also, then you are going to get a positivity or negativity. So that's very important. So tuberculosis attack in a preliminary stage, and let us forget, let it go to the footprints of the medical history with all your youngsters, who is going to take a lot of strain and also interest in controlling. Now we are in NTCP, National Tuberculosis Controlling Program. Let us see, because we are already 71. Our ticket is booked up already to the heaven. We don't know when are we going to clear our ticket. So before that, we want to see that NTCP must come to the National Tuberculosis Eradication Program. Thank you to one and all for having listened to this very marathon session of the webinar on tuberculosis. If any mistakes, please bear with me. If any information that I have to know from you, please inform me. I'll be always grateful to you. Thank you. Respected audience, I may be failing my duties if I don't make a mention for the wonderful, amazing academic work going on in this medical college, that is a government Taranath Ayurvedic Medical College. I am always grateful and also much obliged to the people, those who are directly, indirectly involved in this wonderful, amazing, godly sent academic orientation to the students. Thank you very much.
Thank you, sir, for this wonderful session. Now I request Dr. Lalita Ma'am, Assistant Professor, Department of PG Studies in Kayachikitsa, to acknowledge today's session.
Om Dhanvantaraye Namaha. A very good evening to all. First of all, I would like to thank Dr. Nagaraj sir, who is a famous radiologist and very good, old, and always enlightening and inspiring and very down-to-earth person I have ever seen, and very kind-hearted. We are very much thankful to you, sir, for the wonderful session. And you have not only today, you are enlightening us from years together. Like every Thursday, we have guest lecture from and UG students, even interns. On behalf of all, I would like to thank you, sir. First of all, I thank you on behalf of our principal madam and HOD and all the KC staff. Because of your sessions, really it was a feast, sir. So I thank you again. And not only pulmonary tuberculosis, sir, you have explained extrapulmonary tuberculosis and other sequences. What are the complications and all? Really, it was wonderful session, sir. We are very much thankful to you, sir, on behalf of Kayachikitsa Department, PG Studies, Taranath Government Ayurvedic Medical. Thank you, sir. Thank you.